My talk this morning is on management of fractures in adolescence. And as Mr. Horace pointed out, this does have an element of ambiguity in it because it relies on the definition we use for adolescent. So moving on to that, adolescence, from a number of sources, looks at the concept of puberty. So you're looking at any age between essentially the age of 8 to the age of 16, where the pubertal growth spurt happens, being an acceleration phase, where the velocity of growth steadily increases, followed by a peak height velocity, followed by a deceleration phase where growth slows down and the growth fascial plates close. On average, peak height velocity is reached in girls at the age of 12 years and boys at the age of 14 years, but it's important to note that this is not only ethnic group specific, but also has changed with time. And the reason why looking at adolescent fractures as a specific group is that they do fall between the management parameters for adults and those for children. Certainly there are some often fractures in this group are managed in ways that would be applicable to either the children or adults at the other end of the spectrum, but considerations can be quite different for a number of reasons. So in comparison to adult bone, adolescent bone is less mineralized, similar to pediatric patients, more vascular, and throws down greater callus. The mechanism of fracture leads to the bones are able to deal with greater energy dissipation, meaning that fractures will be less comminuted and do heal quicker as a result of the increased vascularity. In terms of structural factors, importantly, the fascial plates over this period are still opening and moving towards closing. This being a weak point in the bone at which fractures commonly occur. In addition to that, the closure of the fascial plate and the morphology of the way in which specific fascial plates close influences and is responsible for certain fracture patterns like tibial spine fractures and tilo. In addition, there are many psychosocial factors, as there are in many groups, but specific to adolescents, you have issues around compliance with treatment regimens and social acceptance and issues around their meaning that rather than describe a specific age group for adolescents and then use that to determine fracture management, various methods have been described for estimating a skeletal maturity in patients. These range from the very simple to the quite complex. A couple of commonly used methods are the silver grain method, which is a scoring system based on AP and lateral radiography, looking at the progressive ossification of growth plates. You use this on a scoring system to develop a score out of 27. Place this on the curve. You'll see there a curve for girls and boys to determine a skeletal age. In addition to that, there is the Sanders modification, which is of this Tanner 1 House 3 AUS score, which looks at closure of the facies of the distal phalanges of the. In addition to all these methods that have been described, and there's lots of papers looking at the applicability. There are biological staging methods, so certainly the Tanner stages of puberty, in addition to assessment of secondary sexual characteristics. The parameter we use very often in the fracture clinic in young girls is the onset of menses, with a general rule of thumb being that growth plates will close approximately 1 year to 18 months. Important to, I think, at least document assessing girls in this age group, but also to provide the patient themselves and the parents with very clear reason why you're asking such a that with them. I use that very often, and I think we all do for looking at growth plate and ossification centers around the elbow, because I think this is an area where interpreting X-rays, particularly in one ossification of these centers and two So we'll first look at physeal fractures, starting off with some general principles and then moving on to some specific body parts. So Salter Harris's paper back in 1963 described a classification system of 5 types of physeal fracture. There's their original diagram showing the difference between pressure epiphyses and traction epiphyses. Harris 1 fracture being through the growth plate, 2 having a fragment of metaphyseal bone attached, 3 being an epiphyseal fracture line, 4 being a fracture that extends through both epiphyses and apophysis, and 5 being a crush fracture. And they actually described a 5 as a retrospective diagnosis. The paper, since I've forgotten the name, describes a Salter Harris 6, where you get disruption of the perichondral ring of Lacroix. And I do have an easy way for remembering this, but I think it's probably wasted on this population. And we'll use this is useful, 1, for communication, so for describing fractures and having a standardized system, as well as for prognosis. These stages correlate with potential for damage of the growth plate. In general, that being said, certain patterns have higher risk of growth deformity specific to certain. General principles when imaging these physeal fractures are the joint above and the joint below. Comparison views of the contralateral bone or joint can be useful. In addition, particularly for epiphyseal style fractures, CT can be of use, particularly in determining a level amount of displacement and any intra-articular step. And MR can also be of use, particularly in centres that haven't ossified yet, and looking at the periphery. General principles of treatment for physeal fractures in an adolescent population, in terms of reduction, traction and gentle manipulation. Converting to an open reduction is preferable to multiple closed attempts because of the damage that it will continue to do to the growth plate on remanipulation. And certainly no reduction after 7 to 10 days because these heal very quickly, and again you begin to damage the growth plate again unless there's a significant step off. Fixation, so any pins or screws should be parallel to the physes, so you don't interrupt growth. If fixation across the physes is required, it should be a single pass with a single smooth K-wire. Disruption of the physes or the formation of a bar. That would. Certain papers have described resection of the periosteum in relation to these fractures, as well as what's called a Langenskirld procedure, which I've not seen, but is a transpositional graft of most physeal fractures, even in an adolescent population, are reported to heal in approximately 3 weeks, but they do require ongoing monitoring to look at any growth disturbance that has resulted. So this is one classic exercise. These are called Park-Harris lines, which indicate some sort of injury or disruption of the growth plate. This is an algorithm from one of the papers. This looks at when you have a physeal fracture, normal growth, physeal rest, and physeal retardation, and all the various pathways then to go down. The point I like to make around this is that when I was looking at this, I became clear that this is what we following a fracture. On one hand, you want to assure them that we're going to be able to pick up such deformities and monitor them, but on the other hand, make sure that they do attend regularly. And it can be quite a complex thing to describe, particularly. Moving on to non-physeal fractures. So adolescent bone certainly does not have the remodeling capacity of children's, and there are specific to certain fractures, angular weight and specific characteristics need to be taken into account. In general, displaced diaphyseal fractures of these, along with displaced metaphyseal fractures requiring percutaneous pin fixation. Often, most of the time, these fixation techniques are supplemented by some sort of splint or cast or brace external. Locking plates are usually not required because fixation is good. And most of the time, implant removal, you get bony overgrowth of any plates or screws in an adolescent population, as well as any potential disruption to any. There's an example of titanium elastic nails. We'll move on to briefly go through a couple of specific fracture patterns. Looking at the clavicle, so the clavicle is the first bone to begin ossification and the last to finish it. And evidence is, even in adult population, is quite variable. A threshold of 2 centimetres of displacement is often cited in both an adult and an adolescent population as criteria for. But even some of the larger trials don't quite, they're not very specific with this threshold. My understanding was 2 centimetres of shortening was important. But as I said, some of the papers are not that specific. Most commonly in adolescent population, open reduction and internal fixation is considered the most appropriate method of operative intervention. But your considerations are firstly the supraclavicular nerve, which runs right across your operative, the neurovascular bundle and subclavian vessels, which are only. But there are some papers that show earlier return to full activities in adolescents. Studies looking at fractures of the midshaft radius and ulna in an adolescent population are reasonably poor, primarily because they often do not eliminate and often metaphyseal fractures are included. And these can be more difficult to manage than previously thought. Looking at types of fractures, you move from your green stick and plastic deformation fractures right through to complete fractures or common. And it's important to realise that if you do see a deformity in 2 orthogonal radiographs, 2 X-rays taken at right, the true deformity is going to be greater than that appreciated in a single view. So in terms of operative management, 1.5 to 2 millimetre tens nails are often used. Initially, close reduction can be attempted, moving on to close reduction with such percutaneous fixation, and then the progression. One paper reports that says that if you cannot achieve reduction after 10 minutes via closed techniques, open reduction. You want to re-establish the radial bow and eliminate any bowing of the ulna. And certainly the main paper that we've looked at for this presentation advocates fixing the radius and points out the narrow point of the radius is central, whereas the narrowest point of the ulna. These tens nails should not cross the physes and should be removed at about 6 months or more to allow adequate healing of the fracture. That's pertinent at the moment. We've got an inpatient at Sunshine who has a very prominent ulnar wire that's caused some changes in the skin. She's about the 3-month mark, and we've been trying to sort of push things out to make sure that her fractures have united. Moving on to the femoral shaft. So what you want to achieve in fixing these femoral shaft fractures is firstly a timely union with no rotational deformity, less than 2 centimetres of shortening, and in an adolescent population they talk about a deformity of less than between 10 to 20 degrees, depending on what paper you read, in the sagittal plane, and less than 5 to 10 degrees in the coronal. Surgical treatment is favoured once you move to an adolescent population, rather than your paediatric population, which can often be managed. Again, elastic intramedullary nails can be used, but this is more for younger patients and certainly lighter patients. Rigid nails or plating is often used in patients over the age of 11 or with length unstable fractures due to common use. It's important to note that these fixation methods should try and avoid a piriformis entry point, because this can disrupt blood supply to the femoral head and can actually. This being said, there's no randomized trials looking at or comparing these methods of fixation and like most things for significantly comminuted complex fractures, injuries, external fixation is added. But the specific point is made that this cannot often be well tolerated. Distal femoral fractures in an adolescent population are usually very high energy injuries, so need to be assessed as so, looking for other injuries, managing. For metaphyseal fractures in younger patients, closed reduction and percutaneous cross-pin fixation can be used along with the long leg cast. But in unstable fractures in older patients, plating or external fixation. Metaphyseal fractures, for undisplaced or mildly displaced fractures, these can often be managed with long leg cast, with a closed reduction and percutaneous pinning in those that are displaced. But for Salter-Harris 2 fractures with a large metaphyseal fragment, and certainly Salter-Harris 3 and 4 fractures with displacement, some sort of cannulated screw. All these should remain non-weight bearing following fixation for at least 6 weeks. And 50% of these distal femoral fractures of the physeal nature do lead to growth disturbance. And interestingly, slightly different to our general principle, Salter-Harris 2 fractures in this region are at the higher risk of growth. I think the disruption of certainly a fragment of the growth plate means that you're going to get a is going to be an intra-articular. So again, physeal fractures in the proximal tibia are high energy. CT is recommended to evaluate these, and the management principles are very similar to those used in distal femoral fractures. Metaphyseal fractures of the proximal tibia, which are known as Cosen fractures, generally respond well to closed reduction with long leg casting, and genu valgum is the most common complication. Again, we often manage these or monitor these patients until their growth plates are closed in the pediatric population because of the resultant Cosen's phenomenon where you actually get overgrowth. More specific proximal tibial fractures, you have your tibial spine fractures, which are essentially an ACL avulsion style injury, most commonly in the 8 to 14-year-old group. Mr. Harrison, I fixed one of these last Saturday at Sunshine. Usually the result of hyperextension injuries of the knee. And Miles and McKeever described a classification system for these that's been modified a couple of times since, looking at 1 being essentially an undisplaced fracture or avulsion, 2 being slightly displaced, 2 being a posterior intact cortex but hinging posterior side, 3 being completely displaced, and 4 being there are various methods for fixing these, moving from closed reduction for those that are undisplaced. Most displaced ones, though, do require some sort of arthroscopic or open management to this guy, followed by tunnel drilling and fixation by something like fibro wire suture, similar to your ACL, or indeed actual screwing. Tibial tubercle fractures, a classification system described originally by Watson-Jones and then modified by Ogden. We usually now refer to this as the Ogden classification. This most commonly occurs in boys who participate in repetitive jumping. Open reduction and internal fixation is advocated for any 2, 3, or 4 fractures. And a 5 is where you have avulsion of the periosteal sleeve, which should be reattached operatively. And genu recurvatum is the most common deformity associated with. Finally, looking at ankle fractures, some considerations are that the fibular physis usually closes later than the tibial physis, and this can be important when evaluating any physeal disruption on. In girls, the tibial physis usually closes between the age of 12 and 14, and in boys 15 to 18, whereas the fibula a lot later. At least according to this paper. And the tibial physis closes in a moderately complex circular pattern, so starts centrally and then moves immediately around to laterally. CT scanning is recommended at these distal tibial fractures to evaluate. For Salter-Harris 1 or 2 fractures of the tibia, a below-knee walking cast is recommended, though I've not seen this used in our practice. For displaced fractures, closed reduction and above-knee casting for 3 weeks, moving on to a below-knee. And anything of the Salter-Harris 3 or 4 variety often does require open reduction and internal fixation. Often these fractures have a periosteal flap that has become interposed between the epiphysis and metaphysis, and this leads to a 6% incidence of plate closure prematurely. And no more than 5% of angulation in any plane should be accepted with these fractures. Again, our specific fractures in this area, a Tillo fracture is a Salter-Harris 3, so a epiphyseal fragment with fracture extending through the face, occurring anterolaterally in the distal tibia, because this is the final area to close, and thereby the these can be reduced by internal rotation, but often do need open reduction. Triplanar fractures are of the Salter-Harris 3 or 4 variety, and these are described as appearing like a Salter-Harris 2 on the lateral radiograph, whereas a Salter-Harris 3 on the anterior-posterior radiograph. In practice, we almost always evaluate these via CT service. And these occur in patients younger than those with a Tillo fracture, obviously because the growth plate. Interestingly, growth plate arrest is not clinically important in this group. These can often be reduced by flexing the knee up, plantar flexing, internally rotating the foot, and above knee casting. But again, open reduction and fixation may be required. There's a couple of the other sources I used.